All right, I'm just going to go ahead and get started. I think everyone can see me up there. So today we're going to talk about anticoagulation, which I'm super stoked to talk about today. Let's see, let's get rid of this thing so you guys can see my most excellent slides that I did not make this morning. All right, so table of contents, which I always do. So what are the indications? What are contraindications? What are the options? What are the diagnostic workup? What's the mechanism of action and therapeutic options we have? What do we do for reversal? Honestly, the most important part of what you're going to probably experience is perioperative management. So at some point, someone in your career is going to ask, how long do I have to hold apixaban before I cardiovert them? Or how long do I have to hold apixaban before I do their hip replacement? Or how long do I have to hold aspirin before a dental procedure? And so those are the big things you're going to get asked, at least if from an internal medicine standpoint. Or if you know you're doing these procedures, you're going to be asking someone else, but it's good to be familiar with it. All right, so indications. For the most part, it's going to be venous thromboembolism, and so that's going to be your DVTs and your PEs. You can also have clots elsewhere, but for the most part, this is what you're going to be doing it for. The big question that comes up is, should you screen for cancer when you find out someone has a DVT or a PE? And the answer is almost always no. Like, you don't have to go searching for it unless you obviously have a high clinical suspicion otherwise, but in the few studies they've done, they've said don't ever screen for cancer, like just routine screening, unless you're doing their just age-appropriate screening. Prophylaxis, so really the only time we do this is prolonged immobilization. And so when you guys get to your pirate rotation, which several of you will do, the question is how long do you put them on prophylaxis and what do you do for prophylaxis once you send them out? And so usually we do Lovenox and we do it for about 35 days, so it's about 4 to 6 weeks. Usually the orthopedics want it for 8 weeks. Their journals and their data say that that's better studied. Ours says 4 to 6 weeks, and since usually we discharge them, a lot of times they end up going on what we send them on. And then the other thing where this comes up, and now this isn't obviously in this PowerPoint, and it's kind of been recent, is DVT prophylaxis in your COVID patients, which you send out. And so generally, I think what we have done is, and this is actually on the anticoagulation sheet that Vidant puts out, is we usually do, I think, apixaban 5 milligrams BID for about 20 days. And so when you send your COVID patients out, because they're so hypercoagulable, especially during that period, the studies, which are obviously incomplete and not fully supported by the FDA yet, suggest putting on people, and it's currently our policy that we usually put them on anticoagulation for 20 days from diagnosis. And so that's the other thing where this comes in. So I'm trying to put some more recent stuff. And then in terms of provoked versus unprovoked, I think most of us know what kind of goes in terms of provoked things. In terms of cancer or surgery or immobilization, usually you're going to continue to treat through what the inciting factor is. So if they threw a clot because they're being treated with chemotherapy for their cancer, you're going to go through the entirety of that and then treat for the additional 3 months for the provoked DVT. And so it's basically what the underlying risk disposition is, plus the end tail of 3 months. For unprovoked, usually it's the first time you can follow the rules, but it's usually about 3 to 6 months, kind of depending. Now, the other question that's not on here is, do you do a hypercoagulable workup at the time of diagnosis? I think most people by now have gotten that you do not do that. And if you ask the hemonc fellows, they will yell at you all day long. You do not do a hypercoagulable workup at time of diagnosis. Yeah, they're wasted labs. Please don't ever do it. All right. Risk factors. So surgery, trauma, immobility. Immobility is probably the #1 thing that we're going to see from our patients a lot of times because they're bed bound, they're wheelchair bound. They come in saying, I haven't gotten up for a very long time. Surgery is going to kind of be one, especially with our pirate patients, but that's kind of you don't really have to go looking for that because you kind of already know they're going to be immobilized. Malignancy, we don't see that anymore because we don't have our hemonc service, but obviously important. Obviously estrogen with OCPs and hormone replacement therapy. SERM, obviously acute illness. Nephrotic syndrome, I think, is one that I sometimes commonly forget that they're actually predisposed to DVTs and PEs through their hypercoagulability. Myeloproliferative, that's understandable. Obesity, smoking, and then recent caths. All right. I don't want to belabor these points, but just remember when you're admitting people for DVTs and PEs, or you're looking for it, always go through this algorithm of Wells score for DVTs and the Wells score for PEs. Like, when you're presenting the patient, I think they have a PE, you should have this ready and just be able to quote it right off the top. Be like, this is their risk score for this. This is why I think we should go ahead and order the CTA. Or even if someone already ordered a CTA, know what this was, even though it's already ordered, because it's important to understand, what was the appropriateness of this test / what was your underlying risk factors. And so if you say, well, we thought they were a high clinical risk. We thought, so say it's I mean, I hate to bring up COVID again, but say they had a D-dimer of 128,000, they're short of breath, they have chest pain, the CTA came back negative, but it's like, well, we can't see all the branches. I mean, a lot of times you just go ahead and you just anticoagulate them anyway. It's kind of depending on the clinical situation. And so remember, these tests are used to rule in and rule out based on your underlying understanding of their pretest probability. So you should still go through these risk prediction rules to kind of understand what your pretest probability is. All right, duration of therapy, as we said, distal leg DVT, provoked or unprovoked, 3 months, proximal 3 months, upper extremity at least 3 months. Second one, you do extended. Cancer associated, as long as the cancer is active and being treated, you continue it. And then low molecular weight heparin is the treatment of choice. All right. Yeah, that's another thing about treatment. So the other things besides anticoagulation that we obviously can do is inferior vena cava filters. We talked about systemic anticoagulation. You can do thrombolysis. And so a lot of times when people come with PEs, it's not just, oh, start them on heparin or start them on Lovenox, continue treatment. There's technically an indication for targeted thrombolysis if they meet certain standards. And a lot of times that includes activating the PERT team. That is beyond the topic of this topic, but just remember that, it's not just your pills, it's not just your low molecular weight heparin, it's not just heparin. All right. This is the up-to-date algorithm for how to treat it. I just put it on there just to remind you that it's never wrong to go and look things up. Even if you think you have a slam dunk, I know what I'm doing. Never hurts to go and look things back up and go through the treatment algorithms. That's why they invented them. It makes it much easier. I am not going to belabor the point here. I just want to make sure I had it on here. All right, contraindications. There's actually a great little table I found for this. And so absolute contraindications of history of intracranial hemorrhage, intracranial cerebrovascular disease, neoplasms, stroke within the last 3 months. And so if someone comes in, they had a right MCA stroke 2 months ago, and now they have a DVT, it's usually a contraindication. So always ask about stroke history. Aortic dissection is a big one. Active bleeding, obviously. And then recent surgery on the spinal cord and the brain itself is a big one. Relative, now these, I think relative is just kind of evaluate your risk benefits. Age, obviously, because they're more frail, they're more likely to fall. Already using anticoagulation, pregnancy, all these other things. And so we can kind of move on from there. All right, diagnostic workup. This was a great chart. It's kind of busy, and so I wouldn't expect you guys to go through it. But again, it never hurts to go through your algorithms and kind of go through this and see what you're thinking. And so if you see here, you say pulmonary embolism likely, they do their spiral chest CTP protocol or the VQ scan. If you still have high probability, you then kind of go and you consider what you want to do and determine your types of treatment. And you can kind of go through this entire thing. But you can see down here at the bottom is the troponin and the BMP. That's kind of telling you whether you need the echocardiogram to look for the right heart strain and whether you need to go and activate the PERT team. All right, I won't belabor that point. All right, pretest probability, we kind of already talked about that, but just for completeness sake, I like to always have these charts up here. D-dimer is always a risk. I feel like we always play the game of, well, I'll just get a D-dimer and see how it is. And then you always, usually I feel like if you end up ordering the D-dimer, you almost always end up ordering a CTA. BQ scan, we don't need to go over that. We don't need to, okay. All right, therapeutic options. And so what are the choices? And so we obviously have warfarin. We have dabigatran, which is our antithrombin. And then we have our anti-10A inhibitors, rivaroxaban and apixaban. We have unfractionated heparin and low molecular heparin. We have fondaparinol. You have a few other antithrombins, like you have our gatraban, which is an IV form, and you use that for your HIT patients. You can use an IVC filter for patients who can't, who start bleeding when they're on their anticoagulation. Now, I think a great example of IVC filters would be one of the patients on Chief Team right now, who I think everyone knows, end-stage COPD, constantly comes into the hospital. He has a cautionary tale of why we don't admit people all the time and why we don't keep people in the hospital, because he came into the hospital so much for his COPD, they ended up getting a DVT. And so we started anticoagulation, and then he messed up his anticoagulation, and then he started bleeding. And then because he started bleeding, he ended up getting an IVC filter. And then I think he had a complication with his IVC filter as well. And so literally this runs the gamut of why we don't do things in the hospital because of these complications that end up happening. And so it's a cautionary tale about why we admit and why we don't. And so I think the big point to that is people with DVTs and PEs don't always necessarily need to be admitted. If someone comes in with a PE, they have no signs of right heart strain, their blood pressure is tolerated, they're on room air, and they're asymptomatic, you can literally start anticoagulation, send them out just like you can with the DVT. So that is not those diagnoses are not in and of themselves to admit. Now, if you have a clinical suspicion or your ED colleagues are, worried about their clinical condition, that is obviously a reason to admit. And so that's always what you have to kind of balance in these things. Thrombolytics is there. Thromboembolectomy is always there. And then the only other thing that I think we kind of tend to forget about a little bit is when we start low molecular weight heparin or unfractionated heparin and bridge to Coumadin, you technically have to be stabilized on Coumadin for more than 24 hours and for a few days, because even though your INR starts coming down, it's also affecting your protein C and S. And so technically, even though your INR is maybe above 2, because you've knocked down your CNS temporarily and before it equilibrates, you're technically actually hypercoagulable. And so that's why a lot of the times you actually have to keep them for another day, bridging them to warfarin, so they're not just, oh, you hit 2, discharge. It's, oh, you hit 2, give them another day, then you discharge. And so technically that's the guideline therapy. NOAC dosing is at the bottom, but a lot of times pharmacy helps us out with this, and they make nice little prescription packs in Epic, and so that's always helpful. All right, and so I really liked this chart on the online because I thought it was just very helpful about where we see things. And so obviously you can see warfarin affects 2, 7, 9, and 10, which it points out along these pathways. Your unfractionated heparin is going to hit 2 and 3, and so you can kind of see those two. And then your direct thrombin is going to hit right over where was 3? I can't remember where 3 is on the chart, but and then your 10As are going to hit there too. And so I think, oh, here's where this was a very simple but also very clever chart, and where you can see where warfarin hits all along your coagulation cascade and sees the mechanism in action. You can see where your factor 7 deficiency comes in. You can see where Lovenox and heparin come in, where dabigatran is, and then where your factor 10As, like your NOACs, come in. And so kind of gives you an idea of where you're inhibiting and what you're kind of doing. Now, the only really important part about inhibiting these things is what you do to fix them. So I think most of us know that when you're dealing with warfarin and you're dealing with a large INR, you can technically use vitamin K oral, vitamin K IV, and you can also use your FFP to kind of get these factors back. For your 10As and your antithrombins, a lot of times you can use your cryoprecipitate to get that back to, or it was PCC. And then technically for dabigatran, I think you can use Digibind as well. It's exceedingly expensive, but you can technically get around dabigatran. And then technically, I think a new product has actually been approved for apixaban and rivaroxaban as well. I think it's, I think so. It's coming up. Let's see. No, I'll come back to it. Here we go. It is Andinexet alpha. That's the one that's coming out that can actually reverse the direct factor 10A inhibitors. And so you can use the 4-factor PCC, and then eventually you'll be able to use this. And then obviously for dabigatran, you can use Digibind. For heparin, you can use protamine. We already talked about warfarin, what you can do for that, FFP or vitamin K. And then that's it for the most part. I mean, usually a lot of times it's just easier to look these things up. Now, I think the most important part of this is Vidance Intranet actually has the dosing guidelines for this. And so when you're reversing these things, there's actually a protocol for how often you check what the dosing mechanism is. And you can actually look this up, or you can call the pharmacist at night. And so this is never something where you just have to figure this out yourself. This is something where you have the infrastructure and the support here when you need it. And so if you're trying to reverse someone, it's very helpful just to call pharmacy and be like, hey, I'm trying to reverse them. They're bleeding. I put them on heparin for an ACS, but now I can't stop the bleeding. What do I do? And they'll tell you the exact, because it's not just, oh, I gave protamine. It's I gave protamine, I checked a PTT, I decided whether to dose it again. And so there's an entire algorithm that goes through that. All right, now probably the most important point of this talk is how to hold anticoagulation before it starts. Now, our people much smarter than me, including pharmacists, and I believe Dr. Powell and a few others, came together and actually made a chart that shows how long you have to hold these medications based on what kind of bleeding procedure it is. And so whether it's a low bleeding risk procedure, an intermediate, or a high bleeding procedure, how long you should hold these medications so that you don't have to go hunting this down, look for the renal clearance, do all that. And so this is actually available on the internet, and I also can send you guys a copy if you need one. And it goes through everything. This includes apixaban, rivaroxaban, dabigatran, warfarin, heparin, Lovenox, all of it. And so it kind of tells you all of it. Now, the best part about this chart is it's not just the medications. It's also, it goes through aspirin and platinum. So you can see that here. 3 days, you can do your tag. Let's see. It also tells you what constitutes a low bleeding risk procedure, an intermediate bleeding risk procedure, and finally a high bleeding risk procedure. And so rather than having to look these up or try and figure it out on UpToDate, you just go to the intranet, or you can ask me, or I think they used to hand them out. I don't think they still do. But this is honestly one of the most helpful things when you're trying to decide either in clinic or inpatient how long to hold things for. And so it'll tell you what's a low bleeding risk, intermediate bleeding risk, high bleeding risk. And you just go back to this chart and you say, okay, it's an intermediate bleeding risk. They're on apixaban. I hold it for 48 hours. There's technically no renal adjustment for that. And that's it. All right, we talked about reversal. We talked about bleeding risk. All right, now the next part, this is still on the same handy dandy PDF. They talk about bridging. Now, a lot of us have heard about bridging, but it also, this kind of spells it out when you have to do it and when you don't. And so mechanical heart valves, and it literally goes through not just whether it's mitral, but also what type, and then what are additional considerations you have to make for it. And so usually a stroke or a TIA with an aortic valve will also qualify you that you need to be bridged while on an aortic valve. You don't always have to, but sometimes you do. A mitral valve you always do. AFib with CHADS VAS or CHADS 2 of 5 or 6, or a stroke. And so it's always important to kind of go through these things. I think we all kind of have memorized a mechanical mitral valve always has to be bridged. We're not really sure about an aortic mechanical valve. We all know CHADS VASC or CHADS score 2 of 5 or 6, but then these kind of other little, little things here and there, like when was their last stroke? Did they have rheumatic mitral valvular heart disease? And then finally, did they have a thromboembolism in the last 3 months, or did they just severe thrombophilia? And so it kind of really helps you out in going through this. And so you don't have to go and hunt down for this information online. It's literally all there for you. And so, yeah, and so literally you don't, like, it's super helpful. So if any of you want it, please email us and we'll make sure you get a copy of this. Let's see. This is just one what UpToDate has. And so like if you went go looking for UpToDate, this is what it would tell you. And so it would tell you about the renal clearance, but at the same time, it's not going to necessarily tell you how many days you have to do it based on the bleeding risk procedure, which is why I think this other chart is so helpful. All right, and so just kind of going over what MixApp has to offer. So preoperative, usually they want you to hold it 5 days prior. Apixaban, rivaroxaban, dabigatran, usually 1 to 2 days prior. This is kind of from MixApp, so this is obviously a little bit less. This is a little bit less structured than what you're going to see on the inpatient setting. I feel like one of the few times where the textbook is a little bit more lenient than real life is with bridging with procedures and with holding anticoagulation before procedures. I think the biggest question we get asked a lot of the times is when to start and stop it. And so unfractionated heparin, you can do it 4 to 6 hours before what you're going to do. Lovenox is usually going to be 12 hours before. And then when you restart it is usually heparin 24 hours, Coumadin 12 to 24 hours, and then your NOACs 24 hours later. Now that's in general, and that's according to MixApp. Sometimes the surgeon or the proceduralist will say, you can start it today. Sometimes they're going to say, start it within 12 hours. And so a lot of times, like I try and start it a little bit on the more aggressive side, especially if they said they saw no complications of bleeding, their hemoglobin stable, and so I'll start it sometimes that day, especially if it's warfarin, because it's going to take a little while to get back up to dosing. Let's see. So in summary, we kind of already talked about this. These are intermediate risks for bridging, which we kind of already said. All right, so the last part of this is for everyone who's on director's block, please sign in with Joanne Barnhill today. It's very important. I think she's doing the talk at 9 o'clock. And so she'll be talking with all the director's block people. Otherwise, that's a very short presentation on anticoagulation. It's kind of a short topic, but at the same time, the intranet is your friend. Know when to bridge, and then know when to hold anticoagulation before a procedure and how to reverse it. And then always call pharmacy if you're in doubt. Any questions? Yeah, I feel like a lot of the questions. Yeah, what's up?
So does the DVT, like the agent we use, differ in like cancer patients, whether it's a solid tumor or a hematologic malignancy, or regardless of any cancer, Lovenox is the preferred choice?
So I think when I've asked our hemonc colleagues, they're still, their best studies are Lovenox. I think that at least with Eliquis, I think they're coming out with studies soon to show that it's basically just as equivalent as Lovenox is. I think part of it is, especially when they compare it to warfarin, part of the problem with warfarin is it suggests that up to 40% of the time their INR is not therapeutic or within the therapeutic range, which is why they think that Lovenox and some of these other agents are actually better. It's just because warfarin's just not going to be therapeutic often enough for it to work. Last I had heard, and the last time we had a pharmacy talk, I think they were very, they were going to release information about Eliquis being comparative to Lovenox going forward. I think, Sarah, do you have?
So one of the things that I think a lot of the oncologists pay attention to as well is like, is the patient actually going to be able to poke themselves twice, you know, with Lovenox? And a lot of the patients are not going to do that. So they, even though it is like board question, like preferred Lovenox typically, sometimes they will do Xarelto or Eliquis instead, just for that, you know, for patient comfort. There are certain malignancies that are much more like prothrombotic than others, especially lung cancers in particular, adenocarcinomas. I'm not sure about the heme malignancies because typically, you know, they're hypercoagulable, but then if they're also like bleeding or have like cytopenias, like on chemotherapy inpatient, they're usually like very low platelets. So high risk of bleeding too. That's all.
Any other questions? I think the only other thing was technically Eliquis is not indicated for certain extreme BMIs, and it's not indicated for people with renal function, I think, less than 30. That being said, I have seen many, many people use it off-label for people with very high BMIs for similar reasons. They can't tolerate Lovenox. They can't dose them on warfarin. And people with ESRD, when the nephrologist feels more comfortable with it, sometimes they do it too, I think. And so I think, honestly, there's like, I think last time we had a farm rep from Eliquis, they were very excited about using Eliquis either in malignancies, in ESRD, and higher weight patients in the future because they were just running tons and tons of studies because they really thought that their drug was superior. And I think last time I checked, you can also now use it for peripheral artery disease as well at a lower dose. And so there's tons and tons of more uses coming out for the NOACs, and it's nice to know that they're actually coming out with possibly a reversal agent. We definitely don't have it on formulary here to my knowledge. I think you can potentially get Digibine, and I think I've used protamine as well. And then obviously we have vitamin K and FFP and PCC. And so when you run into these things, obviously consider them. And I think that's about all I have to say. Sarah, you have anything else to add? All right, guys, you're free to go. Yeah, there's no data.